Good afternoon, everyone. And we are here with one new edition of the Research Foundation's live session that we have every Saturday. So today's topic is peer review in imaging. And for this topic, we have Dr. Sushma Mahajan as the guest faculty today. It's our privilege to hear her today and to benefit from her experience of doing the peer review for last many years. So it will be, in the order of things to make a brief introduction about her. Dr. Sushma Mahajan is alumnus of Lady Hardinge Medical College and Patiala Medical College, from where she's done her MD of radiology, and training in the Rajiv Gandhi Cancer Hospital in Delhi. She's been working with Bhagwan Mahavir Cancer Hospital at Jaipur since 2010. Now, those of you who are unaware, Bhagwan Mahavir Cancer Hospital in Jaipur is a super specialty oncology hospital. It is the second largest hospital in northern India, a place which is accomplished in terms of the patient care, in terms of the research, and also lots of activities that they do. So Dr. Sushma is the head of the radiology department in Bhagwan Mahavir Cancer Hospital and has been very deeply involved with the quality activities in the hospital as well as in the imaging services. So we requested her to share her experience of doing the peer review, and therefore we have her today here. And I'll now hand over the session to her for her to conduct this presentation. And then towards the end, we can ask questions, whatever we may have. So ma'am, over to you. Thank you, ma'am.
Good afternoon, everyone. I'm Dr. Sushma Mahajan. Today I'll be talking about peer review in imaging, which is a very interesting topic these days, and it's going to be the need of the hour. So I'll be covering, my scheme of presentation is basically I'll be telling about the errors and discrepancies which are common in imaging results and what are the factors which lead to the errors so commonly in radiology practice. And to address those errors, to reduce those errors, we need to have a good peer review system in place. And for that peer review system, what should be the attributes for a good review system? And then we'll be covering about the most commonly used peer review imaging system that is RAGPeer. And RAGPeer has a proper scoring system to tell about the errors. So I'll be telling you about the scoring system and how the scores are interpreted. Then it will be followed by the methodology which we are following in our hospital for the peer review. Introduction. In 1999, the Institute of Medicine reported that medical errors accounted for nearly 1 lakh preventable deaths each year in the United States alone. And you'll be surprised to know that diagnostic errors contributed to an alarming 10% of patient deaths. Not only deaths, basically preventable medical errors prolong the course and duration of patient hospitalization, increase patient morbidity and suffering, and further accentuate the cost of healthcare delivery on the order of tens of billions of dollars per year. It has been found that there is a huge gap between the kind of healthcare that we have today and the kind of healthcare we can or we should have. And there has been an increase in public demand for improvement in the healthcare quality. As Edward said, that it is not enough to do your best. You should know what to be done and then do your best. So over the past decade, the level of interest in improving the quality of healthcare has increased. New requirements established by regulatory organizations require the ongoing practice-based evaluation of physician performance. And it is a fact that the evaluation of physician performance is a very important indicator in improving the overall quality of the healthcare. So peer review is a key process in physician performance evaluation, is geared primarily towards measuring diagnostic accuracy. It is a continuous, systematic, and critical reflection and evaluation of performance using structured procedure. In other specialties, it is still difficult to do peer review because the clinical outcome data are difficult to assess and evaluate. But in radiology, we have a unique condition. And basically, whatever I report today, it is available for everyone else to interpret or review at a later date. The archival system, digital archival system has revolutionized the radiology practice. So we don't have any fear of losing the radiological data. So I feel this achievement it is a boon for all those who are researching the radiological errors in basically practice. So peer review is very much feasible in radiology, and in radiology, adherence to standards of care may be defined by the degree of interpretive agreement between readers, which is believed to be useful for gauging diagnostic accuracy. That is, the evaluation of the physician performance may be reduced to an assessment of diagnostic accuracy, whether a certain diagnostic feature was perceived, interpreted correctly, or reported. So there are three steps to a report. First, whether the radiologist has seen an abnormality or he has missed it. So that is the first step. That is first error, which is perception error. And in case he has seen a lesion, but he is still not able to interpret properly whether it is benign, malignant, fibrotic. So that is second part. That is interception error. And finally, in case he sees a lesion, he knows it is likely benign, but in the report, if it is written query nature, query metastatic, then that is again one error because it is communication error. All three parts of the report are very important, that you have to see an abnormality, you have to see what it is, benign or malignant, and then you have to write it in a proper structured way so that the clinician who has referred the case to you, he must be very clear that you are telling him that this is a benign lesion or a malignant lesion and what further investigation should be done. So that is a very essence of the report. All three qualities should be there in the report. And ideally, it involves a fair and transparent evaluation of performance by physicians' peers to identify opportunities for additional education, error reduction, and self-improvement. The peer review system is done basically to find the errors so that we know these are the errors which are happening in our reports. So then we can work on those errors. We know that this is a pattern. We are missing the findings or we are interpreting it wrongly. So once we do that discussion, then we can reduce the errors. We do additional education and self-improvement for us. Now, coming to the factors contributing to errors, you will be surprised to know that the error rate is very high. It has been reported that 3 to 5% reports are having errors in a daily practice. So, what are the errors? Technical, it may be like your machine is not good quality, it is having a low resolution, or it may be that proper contrast was not given, patient was not breathing properly, or he was not holding his breath. So, all these things can lead to decreased quality of the image. So, that may lead to the diagnostic errors. Then system issues like staff shortage or maybe excess workload or even a inexperienced staff. Like whenever a new radiologist join in our department, we feel that he should be given a cover for 2 to 3 months because it needs time to get used to the culture which we are working, like especially in oncology setup. So all these factors, they lead to diagnostic errors. So we have to cover those. And in case prior reports are available with the patient, that leads to better reports. And clinical information is equally important because with proper clinical information, we are guided in the right direction rather than going in the opposite direction. And now coming to attributes of effective peer review system. Basically, we are interested in a peer review system so that we can learn something from it. So what are the attributes? It should be unbiased, fair, and balanced. Nobody should feel that he is being graded by someone. Nobody should feel that he is basically going to be punished for it. Nobody should have any bias against anyone. The system has to be fair. The cases selected at random to broadly represent the work performed. Nobody should, this case should be done, it is a systematic random sample that nobody can blame that this case was done, taken specifically to harass him. Evaluation process must be consistent with awareness and adherence to the established procedures. A proper protocol should be made how to do the peer review system. Process to be timely so as to represent the current state of performance. Interpretations evaluated within a reasonable interval of the initial report. Review should be ongoing so that data can be tracked over time and analyzed. All these things are basically, if you do monthly reviews, quarterly reviews, or yearly reviews, I feel that monthly reviews are much better because within a month we are able to track the errors and work on them. If it is a yearly review, then we'll be looking at all the errors we have done in a year, that it is not going to be of so much use. And the review system should be non-punitive. Nobody should feel they're going to be punished for a bad score. They should feel that if the score is bad, then they have to work on their errors. They have to work on their patterns so that the report gets better. Nobody should be punished for bad scores. And as we know, the workload is increasing in every department. So it should be a regular exercise 1 to 2 cases per day rather than having 15 cases to be done in one day. Deadline is like 30th and everybody is doing the peer review cases on 18th or 20th. It should be like 2 cases per day or 1 case per day should be given to them, and the doctors should be motivated to participate in the peer review system because it is for their betterment only. So it must only reveal opportunities for quality improvement, help ensure competence, help improve individual outcomes, and provide evidence in cases of adverse and sentinel events. So that is the attribute of effective peer review system. Now, the most commonly used peer review system is RAD-peer. It was built on the premise that whenever a radiologist interprets a new imaging study in conjunction with a preceding comparative examination of a similar nature, there is a professional opportunity to assess the accuracy of the original interpretation and radiologist's performance with respect to that examination. So it is a simple, cost-effective performance tool allowing interpretations to be reviewed for accuracy. The resulting data can then be collected for systematic analysis of the radiologist's performance and to identify possible deficiencies or area for improvement. A well-designed and well-conducted peer review system could provide physicians and healthcare providers with an opportunity to identify patterns of error, intervene, and implement strategies to reduce specific medical errors, which in turn reduce patient harm. Now, coming to the methodology which we are following in our setup, we will cover methodology as required under the quality management system and accreditation standards for hospitals. Though peer review can be done for any modality of imaging, it has been mandated for CT scans and MRI, NEBH 5th edition standards. In our hospital, we are doing peer review for both CT and MRI. Our MRI was recently installed 3-4 months back, so we just started doing on MRI. But for almost 4 years, we have been doing it for CT scan. The sample size as recommended is 1% of total reports. It is systematic random sampling, which is the easiest one to do. But it is recommended to be 1%, but we are doing 30 cases in a month. Periodicity can be decided by the hospital, but it must be sufficient current to enable recall and discussion. Hence, monthly review is recommended. That is what I told you earlier. In case we are doing yearly or quarterly reviews, then it is too late to do anything, any correction. So it should be monthly review, which is very feasible also. And reports to be blinded. That is the original radiologist who reported first must not be identifiable. Nobody should be able to know that who is reporting first case, who is reporting the reviewing second case. To be performed as internal review if number of radiologists are 4 or more than 4, else blinding will not be possible. And external review if number of radiologists is less than 4. I have experience of both external review and internal review. Initially, we were following external review as the number of radiologists were 3 in number. So for 2 years, we were sending our CT scans to another hospital for reviewing, and we were sending 5 cases of CT per month. So in a year, we were sending 60 cases, and it was a quarterly. So we were sending 15 cases in a quarter, and you will be surprised to know that it was a very difficult process, very frustrating for me, because after a quarter, when we used to send 15 reports, it took us around 15, 20 or even 1 month to get the reports back because they were not willing to report. They were not very motivated to report the report. And secondly, when I saw the reports, I was surprised because all the reviewing reports, they were very casual. It was like done for the sake of doing it because our report was very oncology specific and the reports which came, they were not very good. So I was wondering that what is the purpose of peer review in this case because the reviewing radiologist is not doing his duty properly. So it was frustrating and tedious. But as the 5th edition told us that 4 members, so when last year we have a 4th radiologist who joined us. So now since November last year, almost now 1 year, we have been doing internal review. I can tell you very frankly, it is a very comfortable thing because we can manage everything in our hospital only. So what we do is basically, I have told my senior CT technician that whenever a CT scan is done and it is reported by a B or C or D radiologist, he marks it with in front of that. So case number 1 is done by A radiologist, case number 2 done by so and so. He marks it. So after a week, he starts doing assigning the cases of reviewing for the purpose. So in case a case number 1 is done by radiologist A, then he makes sure that the same radiologist does not get the report for reviewing. So he may assign it to B or C or D. So that way he assigns 10 cases to 3 radiologists and they are given a specific time that within 2 weeks time they have to submit the reports. So by 20th we have around 25 reports and last 5 reports we come by 25th. So within 1 week, we assess all the reports, I assess all the reports, and by 30th or 29th, we have a meeting in which we discuss any findings which are significant. So a review is done by HOD basically, and I'm doing all that part, and I'm making a chart in which I have basically NABH recommends that we should follow a chart. I make a chart and send it to my quality team. So now coming to the methodology, because when I see all the reports, then I have to score them according to RATPEER. So discrepancies need to be scored on severity and impact on patient management. So this is a RATPEER score, which is the latest one. Basically, it was modified in 2016. The score is 1, 2, and 3. That means one is when both the reports, the original report and the reviewing report, both are matching with each other, it concur with interpretation. It may not be the fact that both are almost equal in wording or in context. The point is, like in a case of TB patient, he may be having 10 findings. One radiologist is writing 6 findings, one is writing 8 findings, but doesn't make a difference because the finally patient is having TB and the findings are of same thing. So it will be given one score, and one score is to be ignored because there is nothing, no harm is being done, there is no specific error. Now coming to score 2, that is discrepancy in interpretation. When the diagnosis is not ordinarily expected to be made, it is understandable miss. That is, diagnosis is difficult to make. So in case it is missed, so it is again classified further A or B. A is it is unlikely to be clinically significant, B likely to be clinically significant. So in case a diagnosis which is difficult to be made is missed, is it going to have an impact on the patient outcome, A, or B, or not likely to have A? So in case, I'll give you an example, like diverticulum of duodenum is a very difficult diagnosis to be made specifically because it is a very small thing and can be easily missed. So I can give it a score 2A in case it is not having any symptoms. But in case that diverticulum is having infection or it is causing pressure symptom on other organs, then it is likely to be significant. So it cannot be missed because patient is having symptoms and not still you are looking at it. So it is 2B. Now coming to 3, that is discrepancy in interpretation. It should be made, diagnosis should be made most of the time. How basically I explain it to you, like a patient of CA gallbladder comes to us in a follow-up case. He has been operated upon and treated, everything he is doing fine. He just came for follow-up. We get CT abdomen done. Report is normal and the report goes normal, but one thing which was missing was that uterus has been operated upon and uterus was missing. But in the report, uterus was given normal. Now this is a very major error because although it is not likely to be significant clinically because patient is not having uterus, it's not going to cause any problem. But this diagnosis should be made most of the time. This is category 3. So it is 3A. And in case CA breast patient comes, everything is normal, localized disease, lesion is only in the breast with few axillary lymph nodes. But there is one lesion in the bone, but you have missed it. So what now suddenly you have missed a bone lesion which is metastasis. So in that case, stage 1 becomes stage 4. This is likely to be clinically significant because in case of stage 1 treatment is different, in case of stage 4 treatment is different. So it is 3A and 3B. If you miss a finding which is not going to impact him, that is 3A, and 3B is when it is going to impact the outcome. So anything which is 2B to 3, they have to be discussed in a meeting which is followed by a after this interpretation. So all these scores are very important because 1 is okay, 2A you can still ignore, but 2B and 3 are very important. They cannot be ignored and they have to be discussed so that we can work on these areas and improve our reports. Now, basically, what is peer review? As we say, peer review is not a basically assessment. It is like a learning tool. Is quality improvement tool. How it is used, basically, in case we use it as a routine thing, we have to do review and then leave it. No, that is not the purpose. We have to do the review, find the errors, why it is happening. Then if we work on those errors, we do basically meetings and discuss all those points and we learn something out of them. That is the point of peer learning. It is peer review versus peer learning. I feel it is going to be peer learning in near future. Education sessions are at the heart of serious peer learning processes. Now, before concluding, I'll just like to share that in our hospital also last year a new doctor joined. He joined in August and we started peer review in November. So in the last 8 or 9 months, there was a common pattern. In 2 or 3 reviews, I saw that he has been playing safe. Whenever he sees some basically lesion in the lung, he labels it query mets because he feels he has seen a lesion, his work is done. He writes query mets because then physician will think kya karna hai. But that is not the right approach. because what we saw that whenever he writes query meds, the report goes to clinician. Even clinician knows nothing is there because patient is doing fine and there is no possibility of meds. But with the report query meds, now he is in a dilemma, and the patients are well informed these days. Whenever they say query meds in the report, they ask, "Sir, ye kya cheez hai?" So then they have to send the patient for FNAC or biopsy to confirm that it is benign or malignant. So the patient is landing up again in radiology department for confirmation of that lesion, which is most likely benign. So we found that there is a pattern that radiologist is playing safe, always is writing query meds. So we discussed in a meeting and we told him that you have to change the wording, because how the report is formed or structured is also very important. If you write query meds, that is going to basically frighten the patient as well as the clinician. In case you write most likely benign etiology, but meds cannot be ruled out, advise follow-up. That way, after 2 months, when the patient comes again for follow-up, we can see the lesion has increased in size or it is still the same. So that is much better way of doing it. So after that, he started improving his report. Now he is writing very clearly benign or malignant or likely to be benign. And that is, I think, in favor of basically good outcome for the patient. So conclusion, in the current environment of demand for quality healthcare delivery, peer review acts as an essential means to assess performance of diagnostic accuracy and the existence of a quality improvement cycle. Disclosing and discussing errors for learning and improvement requires a just culture that acknowledges human error, avoids blame, promotes peer accountability, and focuses on fixing system deficiencies. Thank you.
So thank you, ma'am. Thank you very much. Very focused and very well presented. I think it should have made lots of issues about the peer review very clear to all of us. If there are any questions, that will be nice. So we could take more questions. Yes, please. Anyone?
Dr. Subramaniam here.
Yes, Dr. Subramaniam, please ask your question.
Yeah. In our hospital, of course, we are doing it on an outsourced basis. And my question is, I think because it is an outsourced, there are two issues coming. One, we have to have a memorandum of understanding, I think, with the outside. Do we?
Yeah, that's right.
Do we need to have a memorandum of understanding? And second, it is a paid service, actually, I think, because they are taking per report, so there are some fees attached. So I don't know how ethical it is, but it is for the quality purpose. We are doing it anyway. But as Madam said that we have more than 4 radiologists, I am planning to change it to an internal review after due consideration. Just I need your comments.
Yes, ma'am.
I think so. That is, as I shared my experience, it was very frustrating for me to do get external peer review done, because you can't make other doctors in the other hospital committed to your purpose. In our hospital, because they are working with me, we are a team, so we can work together and show results. But basically, to expect us doctor who doesn't know me, my hospital, my work, to expect them to do justice to that peer review system, they are not bothered, because they are okay. We are getting paid. It's okay. Hospital management has told us to do it. We'll do it. But they are not paying attention to very casual attitude. So that can't be addressed sitting at my hospital. So I feel internal review, in case you have 4 radiologists or more, it is the best thing to do.
See, Dr. Subramanian, the issue is like this. You have to have, firstly, the requirement is to be non-punitive, which means we cannot penalize or we cannot punish a person whose report is being reviewed. So in order to be non-punitive, we need to make it, we have to blind the reports. Now, if you have a radiologist, total radiologist less than 4, then blinding is not possible. It will be very easy to find out whose report it is. That is the reason the external peer review is required, because then once you disclose whose report it is, then obviously the whole purpose of quality improvement system is lost. That's the reason for external. Now, a lot of hospitals, what they do is you can also outsource the peer review, like you have done it, and you pay for the second report also, the review reports. But a lot of hospitals do on a exchange basis. That means hospital A reviews the reports of B, and the hospital B reviews the reports of A. Now, in that situation, the question of firstly the fee is neutralized because you're doing each other's work. Secondly, the commitment also is slightly better. That is what I have seen in my experience working with many hospitals. But yes, if you have the number of radiologists 4 or more, then it is obviously much better to have these internal review. And obviously, then you can do blinding, and therefore internal review is a good idea. And then entire process is also under your control. So that way it helps. I hope it has answered your question.
Yeah, very well. Thanks.
There is one question in the chat, it has come. Dr. Jaswant Arneja has asked, what about calibration?
Calibration of what, sir?
Does the calibration affect the reviews or the reporting?
No, I feel when basically nobody is we are not telling that this report was done wrongly or this report was, we are just taking out the findings and we are telling that in case of such type of report, we should write query or what. So that is the purpose. We are not disclosing that you have done this wrong if you have done this wrong. So it is not basically, we are not having any punitive action or nothing of the sort is there.
No, I think the question is about the calibration of equipment, imaging equipment. So as it was there in the presentation as well, that the technical issues will have a bearing on the quality of image that you capture. So if the calibration is not being done, obviously it will have the bearing on the quality of the image itself, and therefore the impact on the quality of reporting as well. So that is something which is not really connected with the peer review itself. It's the equipment maintenance issue. That is what I think Dr. Jaswant is asking. He has one more point. If you have 1 or 2 radiologists only, then what?
In that case, only external review can be done. You can't afford to have a...
Yes, ma'am. The blinding will not be possible.
Yeah, definitely. It can't be possible.
Yes. So that's okay, Dr. Jaswant. I think you have, if there are only 1 or 2 radiologists, then the only option available is to do the external review.
One small comment, Dr. Rakesh.
Yes, please.
Yeah. See, actually, because the whole system here is electronic, EMS system, electronic medical records. So when I would love to have it blinded internally, but the problem is when we give a particular radiology for this RAD pair, obviously we have also bound to give the clinical data to that doctor who is trying to give the alternate report. And the clinical data is available on the electronic medical records. And in the electronic medical records, if this case is already reported, that also will be coming in. We cannot remove that. So it is my suggestion. I think I will try to, what I am planning to do is the moment the patient is getting radiographed, that time itself, simultaneously, I would like to give it to the official report, of course, by the concerned deputed radiographer. At that time itself, I will be sending it for the quality report checked by another radiologist at that time itself, so that they don't have the advantage of having the report already there, and that error won't happen. So that is, I think, maybe an improvement in hospitals.
I agree with you, sir, because I think nowadays the trend is changing from retrospective to prospective, because earlier we used to review the earlier cases, but now they are saying before the report is dispatched, so that the error can be caught at the right time, rather than going to the patient and outcome is affected, then we say outcome was affected. It is like better to have, like in a day you do 2 cases of peer review, 2 radiologists do it simultaneously on the basically the system, and before the report is dispatched, so that you can capture that error before that. So that is the right way of doing it.
Yeah, exactly. Thank you.
That prospective peer review is better.
Yes, ma'am, there is no doubt about it. I think that is an improvement on the peer review itself. That instead of doing a peer review of a report which was done 3 days, 5 days, or maybe 15 days back, you do it as soon as it is feasible. The idea, Dr. Subramaniam, the idea of blinding is that it is not known as to which radiologist or who has reported for the first time and who has reviewed it. Now, the whole purpose is essentially what? What are we trying to achieve? I mean, we have discussed this in earlier occasions also, whenever we talk of quality improvement. The requirement of eliminating the punishment from the entire game is most important. Because if you start identifying people, then obviously at some point you cannot stop blaming them for whatever error is there. And the moment this blame thing starts, then the entire understanding changes. People will try to avoid participating in such activities. People might also, might also hide the findings. Of course, in this particular peer review, you can't hide it. But like in clinical audits, we've been saying that it should be always non-punitive in nature so that things get reported. Because if they don't get reported, then you will never have any method to improve. So that is the reason of blinding. But of course, if you do a concurrent review, like before releasing the report, if it is being reviewed by two people, reported by one, reviewed by another, then obviously it improves. It is an improvement on the peer review itself, and also it is a much better system, a much better way of working. Any more questions? I think Dr. Jaswant has one more. I can see the chat. What about the intelligence, artificial intelligence in reporting? Ma'am, your comments.
Yeah, artificial intelligence is good, but I don't think so it can match the human capacity because findings can be seen, but how to interpret, that is basically what a human brain can do. I don't expect at this stage that it is so much capable of interpreting the complex findings and to make a one diagnosis out of that. That's still not possible.
I think I'm aware that at a pilot level, the Dr. Mahajan, Dr. Harsh Mahajan, who has this Mahajan imaging in Delhi, they have done a lot of work on use of artificial intelligence in interpretation of images, and a lot of work has also been published in lots of journals. So a lot of path-breaking work is happening, but I think Dr. Adneja, we have not reached a stage where the reporting can be entrusted to AI. So we wait whatever, if at all it happens, because the human element will always be most important. Even in reports which are AI, AI assisted, even then you need a human intervention to finally,
Definitely, like in case of breast mammography, they're using that computer-aided detection, but even then you need to have a human intervention at a certain point because it may be more sensitive, but it will not be so specific.
Very true.
You have to have that.
And then, of course, I mean, we haven't replaced the human mind as yet, so I guess the artificial intelligence will remain what it is.
So the views of hello.
Yes, yes, Dr. Adneja, please.
May I say one sentence only? The views of two humans may differ, but the AI report will not differ at all.
Agreed, sir. It will be an aid. That is what the point is being made. That it will be an aid as an assistance, and possibly it will have a lot of value there as an aid. But whether we would be in a position to trust AI-generated report in that manner, well, only future can tell us.